Okay, this is title talk or title slide, and I do not have any disclosures. There we go. This is my talk outline. It's been a long time since I last presented here, and as a trainee, I did give lots of talks here. Today I want to talk about two separate but somewhat related projects that I've been working on over the years. And since this is grand rounds at Lab Medicine, I have decreased the scientific detail, and I have some good clinical tie-ins, including some case presentations on both erythroid leukemia, and I want to discuss some of the diagnosis and controversies. And then I want to switch gears and talk about a very rare but aggressive form of pediatric myeloid leukemia, which has an acute Megakaryoblastic pattern. And we did some modeling studies where we identified good targets, and it's gone straight from the benchtop to the bedside, where we're now trying to start up a clinical trial. So when I left the hutch, I was very interested in looking at cell cycle regulation and the impact it would have on genomic instability. So as a brief background, cell cycle is driven by a family of kinases that are present for a very brief window in the cell cycle. They partner with, a family of proteins called cyclins that are present for a very brief window in the cell cycle. They bind to their cognate kinases, and so the kinase activity is present and then rapidly shut off. The question we asked was, we were working on cyclin E, which promotes S phase. What happens if we were to stabilize cyclin E throughout the cell cycle? Would that cause hyperproliferation, genomic instability, or a cancer-prone phenotype? So we ended up making two separate mouse models. We degraded what's called the phosphodegron. These are the sites that gets phosphorylated and then targeted for rapid ubiquitin proteolysis. And we found that it had a very minimal cell cycle phenotype. And that was because it activated the p53 pathway, which then resulted in p21. p21 is a cell cycle kinase inhibitor. And so basically, there was a lot of other pathways that impacted this kinase activity. When we expressed it in a p53 null background, we found increased cell proliferation, genetic instability with chromosomal abnormalities, and a cancer-prone phenotype. What we didn't expect is that these mice also developed a significant splenomegaly with erythroid hyperplasia and macrocytic anemia. And what Dan didn't tell you is that's one of the reasons why I returned after this to train in hematopathologists so I could help diagnose my mice. So this is a slide showing the different spleen sizes of wild type, and this was one of the larger spleens we had in the mutant cyclin E. When we looked at this under sections, you can see the white pulp, which is these little blue islands, which has mostly lymphocytes, is pretty much maintained. But the big difference in the cyclin E mutant mice is in the red pulp, where there was a lot of immature erythroid cells. Now in mice, the spleen is somewhat of a hematopoietic organ, and I did have a lot of arguments with people whether this was reactive versus a leukemia. We looked at the peripheral blood on these mice, and we saw an interesting pattern in the mutant mice that there seemed to be an increase in reticulocytes. These are these gray cells here in the peripheral blood. We then looked at erythroid maturation by flow cytometry, and one of the classic ways of doing that is to look at CD71, which is the transferrin receptor, and TIR119, which is the glycophorin-associated protein. And when erythroids mature, they first gain CD71, then they gain TIR119, and then they lose CD71. And if we looked at this pattern in normal cells, we showed a good progressive maturation. But in our mutant mice, there seems to be a block in the maturation, so there was a high number of these double positive cells. We sorted the double positive cells and looked at the cell cycle, and we found a lot of these cells were actually in S phase, suggesting that the presence of cyclin E was inhibiting cell cycle exit, and it was also inhibiting maturation of the erythroid lineage. So to go forward a number of years, we wondered whether that could be a premalignant phenotype. So could we get erythroid leukemia in these mice? And so we set about it with a genetic experiment, which is an insertional mutagenesis using a Sleeping Beauty transposon system, which was designed to either activate or disrupt the genes. And there was multiple copies per cell, so it could then mimic multiple mutations. And it was easy to identify the target genes. I was very skeptical that this would work. One reason was because erythroid leukemia is a strange diagnosis in humans, and it's very, very rare. And at the time we started this, most cases were really a myeloid leukemia with erythroid hyperplasia. This sort of outlines what I told you. These transposons have a promoter that would activate oncogenes. They also have stop codons that would inhibit tumor suppressor genes. But in order to inhibit the tumor suppressor genes, it would have to have 2 hits. So it's much better as an oncogene screen. And what's usually done is people isolate the tumors and they look for common insertion sites. We were at a disadvantage because in our model system, we only got 1 tumor per mice. Whereas if you were doing this in the colon, you can get 20 different tumors and study. So we were somewhat limited. I was very surprised. 2 months later, after we started this experiment, I was on service at the Seattle Cancer Care Alliance, and the Alliance lab downstairs called me up and said, "We have an interesting peripheral blood we wanted you to review. It has these very large atypical blue cells here. And by the way, this was brought over by a researcher from the Hutch, and it's a mouse model." So I realized we probably had something. And under higher magnification, you could see these cells have open chromatin, it's somewhat blotchy, and a very deep basophilic cytoplasm. This is pretty classic for proerythroblasts. And in my time at the Hutch, I have never seen circulating proerythroblasts like this. We found these cells in the bone marrow, we found these cells in the spleen, and we found these cells in the liver. And this shows a cytospin of cells from the bone marrow and the spleen. And what I wanted to point out is some of these cells did have these peripheral blebs, which are characteristic of megakaryocytes. So there may be some megakaryocyte differentiation. And indeed, in some of the models, we did see wildly atypical cells that showed some degree of maturation to megakaryocytes. By flow cytometry, we showed that the red population here is the abnormal population. It had low CD45, high CD117. This is c-KIT, it's an immature marker. It had CD71, but really no TER119. So these are immature erythroid cells. And we showed similar populations in the peripheral blood, bone marrow, and spleen. However, when we looked at the survival of these mice, we did not see a significant difference between the mutant mice and the wild-type mice. And in fact, when we looked at the different disease spectrum, most of the mice developed a T-cell leukemia or lymphoma, which is very common in mice. The cyclin E mice did develop more of the erythroid leukemia than the wild type, but it was not significant. So then we looked at the insertion sites. Now, the average tumor had between 40 and 120 different insertion sites. And this was a great list. I got all excited because a lot of these were cancer associated, and it was very hard to figure out what was really functional. And the question was, first of all, how many driver insertions are required for tumorigenesis? And is this a clonal population? What I forgot to tell you is that this system starts off with 300 different transposons. And every time the cell divides, these transposons hop around. So it's a huge mutagenic insult to these cells. So the way to identify, most labs use this common insertion site, but we didn't have a huge amount of tumors. We were able to get 5 different cell lines growing, and we selected over a long, prolonged cell culture to see, with the idea that as the cells keep growing, they may lose some of these transposons. This is our list of genes that were hit with erythroid leukemia, and these first 2, ERG and ETS1, were found in the vast majority of tumors, and they were mutually exclusive, or mostly mutually exclusive. So let's discuss these. ETS is a large family of transcription factors. It's frequently upregulated in cancer by either translocations or amplifications. And it's actually a poor prognostic marker for leukemias. ERG itself, which we chose to focus on, is a regulator of self-renewal in early hematopoietic cells, and it inhibits differentiation. It's probably best known in the translocation in prostate cancer, where you have an androgen-responsive promoter is fused to ERG. It's also present in transient acute Megakaryoblastic leukemia, which we'll discuss coming up. So I did a lot of studies. This is the one that I wanted to present. So ERG, we noticed the insertions were all in the same direction, and they were all at the sort of start of the gene, suggesting that we are seeing overexpression of ERG. And we did confirm that on Western blots. We tried to knock down ERG, and it was very difficult to knock down because in these splenocytes, when we knocked it down, the cells were dying. So they required ERG to keep growing. We were able to select conditions where we knocked it down a little bit, and the cells that were derived from the wild-type cyclin E did show maturation, where you see with the knockdown, you get some TIR119 expression. However, the cells with the mutant cyclin E, we did not see any significant maturation, suggesting the cyclin E may still be having a role here. While I was working this up, I made the mistake of presenting preliminary results at ASH, and I had a long talk with Catherine Carmichael, who told me that they had made the ERG transgenic mouse and found some interesting things, but they were no longer working on it. 4 months later, I got an email saying, well, I couldn't tell you now, but our paper's now in press. And so they identified ERG and ETS1. Interestingly, they did note a relationship with JAK2 also, which we did not see. So the summary of the erythroid leukemia studies is Sleeping Beauty insertional mutagenesis does promote erythroid leukemia mediated by ETS transcription factors. And I should say there's been several other papers that have come out showing a similar thing. Expression of mutant cyclin E did promote growth factor independence and inhibit differentiation of the erythroid leukemia cells. ERG is a viable target for erythroid leukemia with ERG expression, but the big question I had in my mind is, what are we really modeling? Is this erythroid leukemia? And if so, why is it so common in mice and so rare in humans? So I want to switch gears and present a quick recent case I had, and then discuss the diagnosis of erythroid leukemia. So in this case, we had a 66-year-old male who was a long-distance runner and noticed some fatigue on his run while he was running. The outside lab reported pancytopenia, and the bone marrow was interpreted as a hypercellular marrow with atypical mononuclear infiltrate suspicious for a high-grade neoplasm. It was then sent to Cleveland Clinic, and they described it as an acute leukemia with erythroid differentiation consistent with AML with MDS-related changes. So I looked at it, and it doesn't quite meet the WHO criteria for AML, and so I called up the late and great Eli Esty, who had all these words of wisdom, and before I could say anything, he said, clinically, this looks like a high-grade myeloid neoplasm, and the patient deserves high-intensive therapy. And I said, well, don't you want to hear my interpretation of it? He said, sure I do, but it doesn't matter. I'm still going to treat him with high-intensive therapy, which I somewhat agreed. So it's a 66-year-old male. This is the bone marrow biopsy. It is hypercellular. And if you look closely, you can see these very immature cells infiltrating throughout the marrow. These cells have sort of blocky nucleoli, and they do really look like erythroid cells. On the bone marrow aspirate, where we get a little better morphology, these cells have a dark blue cytoplasm, opened chromatin, again a blocky nucleoli, and in some cases they have a vacuolated cytoplasm. In the subsequent marrow that was done at the UW, by flow cytometry, they did notice an abnormal CD34 positive myeloid blast population, but this only represented 4% of leukocytes. And so one of the take-home points is flow cytometry is very specific for myeloid cells and lymphoid cells, but it usually does not survey erythroid or megakaryocytic cells. For the erythroid cells, there's usually erythroid lysis, which gets rid of much of the erythroid cells, and what remains is gated out. So then I did some IHC studies, and you could see that our results correlate with the flow cytometry, that there were rare CD34 positive blasts. There was an expanded population of CD117 or c-KIT positive cells. These could either be immature myeloid or erythroid precursors, or in some cases, mast cells. We stained for ecadherin, which stains immature erythroid cells, but has a wider spectrum. So a lot of people generally think of this as more of an erythroid marker. And so we saw about 30% immature erythroid blasts and 60% erythroid precursors. We did not see any CD61 expression. This is a megakaryocyte marker. Some people suggested to me that we should just call this an acute leukemia based on CD117 and ignore the ecadherin that sort of suggested these are erythroid blasts. The diagnosis I came up with was a myeloid stem cell neoplasm with predominance of immature erythroid precursors and high-grade features with CD34 positive blasts comprising less than 5% cellularity. Per WHO criteria, this should be a low-grade MDS. I usually write a large comment section saying that I'm worried this is a developing erythroid leukemia. Cytogenetics came back and it was a complex pattern. They did have a P53 mutation, although when I checked on it, it had a low variant allele frequency. He was treated with GLIS, which is a high-intensity regimen with persistent leukemia. So what is erythroid leukemia? Erythroid leukemia is a very rare type of acute myeloid leukemia that is distinguished by erythroblast proliferation. It's been also termed de Guglielmo's disease. In 2008, the WHO divided it into two classes. M6A, or the erythroid myeloid type, which represented 95% of the erythroid leukemias, basically had an erythroid hyperplasia with greater than 50% erythroid cells, and then an expanded myeloid blast that represent greater than 20% of the non-erythroid cells. So the case I showed you probably would not meet even that criteria. It was basically an acute myeloid leukemia with erythroid hyperplasia. The more rare form is this pure erythroid leukemia, or M6B, which is defined as 90% of the marrow cells are immature proerythroblasts or basophilic erythroblasts. In 2016, while we were working on this study, the diagnosis changed so that they got rid of the M6A. They decided it was too complicated to count blasts and define it based on non-erythroid cells. And they defined it as greater than 80% immature erythroid precursors with 30% proerythroid blasts. Most M6As now are reclassified based on the CD34 positive blasts compared to the entire marrow. And so I would interpret that as usually a low-grade MDS. These are some pictures I got from the most recent WHO, where you can see these erythroblasts, again, open chromatin and vacuolated deep basophilic cytoplasm. They're scattered immature cells infiltrating here. Many of these cells stain for CD71 or the transferrin receptor, which is a good erythroid marker. And a lot of them have very strong, bright P53 expression. Now, P53 IHC is a little bit counterintuitive because a lot of the mutations that inactivate P53 actually stabilize the protein. So to see very bright, strong P53 expression is suggestive of P53 mutations. This is a recent article from an international collaboration. The senior author is Thomas Murcher, in which they accumulated 33 acute erythroid leukemia samples, and they analyzed them for mutations and gene expression. They classified them into 3 groups. The first was TP53 mutated, that represented about 36%. Then there were the epigenetic regulators, such as a lot of MDSs, which represented 33%. And then there was undefined cases with a very low mutation burden. They went on to say that about 25% of them had aberrant expression of either ERG, ETO2, or SCY1. And they made a mouse model in which they overexpressed ERG either in a wild-type background or a P53 mutant background, and they showed the combination of ERG and P53 induced a very, very aggressive erythroid leukemia, where ERG by itself did induce erythroid leukemia, but it was not near as aggressive. So a lot of the groups now are claiming that all erythroid leukemias do express or do have mutations in P53, and actually one of the groups I'll talk about has said that maybe we should molecularly define erythroid leukemia based on these P53 mutations. This paper here, they looked at erythroid leukemia and they said sometimes you'll get a P53 null phenotype where you really don't see any expression of P53 versus an erythroid leukemia that has a mutation in P53 where you get very bright staining. And this is compared to the control. And so what I wanted to point out, in the normal marrow, you do see some cells that have dim and variable levels of P53. So there is a big difference between the control versus the P53 null. One of the problems with diagnosing erythroid leukemia is there are a lot of reactive disorders that can produce a similar pattern, such as vitamin B12 deficiency, autoimmune hemolytic anemia, or beta thalassemia. So in this paper here, they were suggesting that in these reactive disorders where they did have a high level of immature erythroid cells, P53 staining is a good way to differentiate from these reactive disorders. So as we were discussing prior to the talk, recently in hematopathology, there's a huge controversy. There's 2 separate groups that have come up with separate but related diagnostic classifications. There's the WHO group, which now defines it as acute erythroid leukemia. They kept basically the same criteria, but they note that in a lot of cases, samples that do not meet this very stringent criteria can be defined as myelodysplastic neoplasms with biallelic P53 inactivation. The other group, which had all the hempath gurus, is the international consensus classification, and they actually eliminated the diagnosis of erythroid leukemia. Instead, they thought that this should be defined molecularly just based on P53 mutations. In general, if you look at the classification scheme, there's an awful lot of tumors that are now classified either by cytogenetic or molecular data with much less of a morphologic component. I have 2 questions to raise, and I don't think there's a good answer. In Thomas Murcher's paper, he was saying that a lot of the cases he looked at did not have p53 mutations. So what is the percentage of p53 mutations? And is it only the erythroid leukemias that have the p53 mutations, the really aggressive ones? And what I forgot to point out is that the diagnosis of pure erythroid leukemia is extremely poor, with a survival of about 2 to 3 months. So if this has such a very limited survival, should the diagnostic threshold be so high for that? Or should we try to figure out a way of diagnosing it earlier? Okay, so I'm about halfway done, and here I usually have a cartoon. I apologize, I did not find a good cartoon to present. I was reading up on ERG while I was writing this paper, and I came across this review article, again from Thomas Murcher's group, where he shows there's a competition between ERG and GATA1. ERG usually is found at high levels in immature cells, and over time GATA1 is overexpressed and outcompetes ERG, promoting either megakaryocytic or erythroid differentiation. ERG is on chromosome 21, so patients who have Down syndrome frequently have increased ERG. They develop what's called a transient abnormal myelopoiesis, where you find a mutation in GATA1 that results in a truncation of the protein. This is a very interesting disease process, because it basically looks like it's Megakaryoblastic leukemia, but it's transient. It goes away without treatment. There is a limited self-renewal of these cells. About 10% of patients who have this transient abnormal myelopoiesis will then go on to develop Down syndrome, acute Megakaryoblastic leukemia. However, there is a rare but highly aggressive form of pediatric AML, which has this fusion protein, ETO2 GLIS 2, that stimulates the expression of ERG. So these have very, very high levels of ERG. About that time, Sohail Mashensky, who worked in the lab across the hall from me, and we used to discuss science together, came by and said he was all excited. They have a new project they're working on where they're going to express some of these fusion oncoproteins within stem cells to try to model pediatric acute myeloid leukemia. And he wanted to know if I wanted to work with them. More specifically, he wanted to know if I would look at these cells, make a cytospin, and look at them by flow cytometry. And then he says, oh, by the way, the abstract's due this evening for ASH. So we did get it out. These cells, to me, looked pretty good for megakaryoblasts. You can notice the peripheral blebs. In the cells in culture, it's a little bit different a lot of times, I found, where you have sort of this biphasic staining pattern. We have a skirt that's deeply basophilic, and then you have this sort of purple granular material in the cytoplasm. By flow cytometry, we did see CD117, the immature marker, and 2 markers for megakaryocytes, CD41 and 61. So that's pretty good for megakaryoblasts. They did not have any CD71 expression. Then later on, I found that this was a fusion with CBF-A2T3 GLIS 2, and I'm just going to call this, for the rest of the talk, CBF GLIS, is the same as ETO that I had shown you on the previous slide from Thomas Murcher's thing. So this is a process that has very high levels of ERG, it's been shown. CBF GLIS develops from a cryptic translocation between the long and the short arms of chromosome 16 that's frequently missed by classic cytogenetics. It specifically drives the overexpression of ERG, which competes with GATA1 and keeps these cells from differentiating. A little background on pediatric acute myeloid leukemias. These are de novo leukemias with very few genetic abnormalities. In fact, it's thought that they are driven by unique fusions that are thought, in some cases, to be sufficient for leukemic transformation. In other cases, they partner with a few other mutations. These fusions are found either in very young infants, or they're found in young kids, but they're rarely found in adults. In contrast, adults' AML usually develops from a chronic disorder like MDS, which has multiple genetic and chromosomal abnormalities, and they are very distinct from the pediatric AML. So I have a second case to describe. This was given to me by Karen Chisholm at Seattle Children's Hospital. This is a 2.5-year-old girl who had bruising and fever for a few months' duration. On her CBC, she had thrombocytopenia, and she had a workup for ITP. In the bone marrow, they noticed 70% blasts, and she was diagnosed as acute Megakaryoblastic leukemia. They sent this to Foundation 1 for genetic testing, and that was negative for fusions and genetic mutations. Under the microscope, these cells looked pretty good for Megakaryoblasts. They have open chromatin, deeply basophilic cytoplasm, and they have these peripheral blebs. The bone marrow biopsy just showed these immature cells. It's very hypocellular for age. And you'll notice that a lot of these cells line up, like there may be some fibrosis there. By flow cytometry, the leukemia is this big red population. They were positive for 117, variable CD33, negative for CD34. They had high levels of CD56, although that was variable. And then they also had the megakaryocytic markers CD61, CD42, and CD41. This has been termed the RAM immunophenotype. So in Hematologics, which works pretty closely with COG and Sohail's lab, they were classifying different acute myeloid leukemias, and they found that there was a unique population that expressed very high levels of CD56, very low levels of CD38, and very low levels of CD45, and that this population had a very, very poor prognosis. It was later found out these represented CBF GLIS AML. So this patient was enrolled on a clinical trial with bortezomib and sorafenib, and she relapsed 6 months after the diagnosis. The data was re-examined. The Foundation 1 data was re-examined, and they did identify the CBF GLIS cryptic fusion. She was then treated with azacitidine and venetoclax with persistent disease and started on a clinical trial with mesothelin CAR T-cells with a poor response. Although CBF GLIS is somewhat of a rare AML, it is very, very aggressive. It's found exclusively in very young infants and very young children. And if we compare this to your garden variety pediatric AML, there's a much worse prognosis on these patients. In fact, Sohail says the only patients he's seen survive at all are patients who are able to become MRD negative after a bone marrow transplant. Acute Megakaryoblastic leukemia is defined as greater than 20% blasts with megakaryocytic differentiation. It's, again, a somewhat rare form of AML. It's much higher in young children and rare in adults. We can classify it as children with Down syndrome, which have this transient abnormal myelopoiesis that I described, or a myeloid leukemia associated with Down syndrome. Children without Down syndrome frequently associated with one of these fusion proteins, including CBF GLIS, and cases without the fusions have a focal amplification of the Down syndrome critical region, which involves RUNX1 and ERG and ETS2. Adult cases are much less well-defined. And these are some pictures I got from the latest WHO showing that these leukemias can be fairly pleomorphic, or they can be very monomorphic. The cells themselves frequently have these cytoplasmic blebs, and it's usually associated with increased myelofibrosis. By flow cytometry, it expresses these markers with either a CD117 or a CD34. And what I forgot to mention is our lab, our clinical lab, does not usually use the megakaryocytic markers because platelets are very sticky, and it's easy to get a platelet sticking to a blast and misinterpret it as a megakaryocytic differentiation. Since they do have so many acute megakaryoblastic leukemias at Seattle Children's, they do include those markers. So I started working with Soheil's group, modeling pediatric AML, and this has been enormously productive. We established cell cultures and xenograft models using fusion-associated fusion-associated pediatric AML. One of the questions we were asking, is the fusion sufficient for inducing AML or are other mutations required? What are the molecular mechanisms promoting malignant transformation? And these studies can then facilitate drug, genetic, and immunotherapy studies. And then finally, we're asking, does the developmental stage of the stem cell that we transfected affect the fusion-induced transformation? So it's generally thought that the transient abnormal myelopoiesis develops from probably a fetal liver cell or very immature stem cell that has limited replication potential. And so there is differences between these different stem cells. We set up culturing on endothelial co-cultures, and we found that with the endothelial cells, it would let the cells grow. Usually if you take stem cells and you put them in culture, they'll rapidly differentiate. There are conditions that you can use to inhibit their differentiation. But with these endothelial cells, we were able to culture these cells for up to 12 months, and they still had good replication potential. The interesting thing about this is if you look at endothelial cells versus stem cells, this is supposed to mimic the stem cell niche, but it's also found in dormant tumor cells. So I work with Cyrus Gajar at the Hutch, and he's looking at a lot of breast cancer cells that are dormant and just sitting around. And he thinks the endothelial cells reach out and keep these cells in dormancy, and that's why some patients redevelop breast cancer 5 years later. The endothelial cells did promote proliferation of these cells, and while the cells that were grown without the endothelial cells sort of stopped dividing and crapped out after 9 weeks, the cells that were grown on the endothelial cells kept going for over 12 weeks. We showed that direct contact was required to get the maximal effect, and even after 12 weeks in culture, these cells had significant self-replication activities in colony-forming studies. These cells were then injected into immunodeficient mice, and both the endothelial cells, including the cells that were grown for 12 weeks in culture, produced a very aggressive leukemia, where the myeloid cells from week 3 and week 6 also were able to produce the megakaryocytic leukemia. We did serial transplants and shown that this disease is actually transplantable, so it is a leukemia. And then we looked at the cells under the microscope. So this is CBF GLIS cord blood cell xenograft, and this is the bone marrow biopsy, versus the lower one is CBF GLIS patient-derived xenograft. And you'll notice that the cells look somewhat similar. We found this is a very focal process, so it's not diffusely involving the marrow. Sometimes in these mice you do get a huge amount, but other times it was very limited. But what I was the most excited by, and you have to look closely, is these cells all seem to attach together. This is somewhat of an alveolar pattern where you have a lot of focal adhesions between these cells. And this may be one reason why they're so difficult to treat, is because it's more of a solid tumor. The other possibility that I was wondering about is, since these cells all express platelet factors, if you get some circulating cells, and you usually don't get many circulating cells, could these be inducing some sort of a thrombosis? So we compared flow cytometry pattern of our model to patients, and we found that they did express the RAM immunophenotype. We then went ahead and did some IHC studies, and they were positive for CD117 expression, CD56 expression, which is a good marker for CBF GLIS, and ERG expression. And this is comparing it to a patient sample that's stained for CD56. So then we looked at gene expression. And what I don't have time to tell you is during those 12 weeks of time, I thought when we put in the fusion, we'd get an immediate transformation of the cells. I didn't think it would take 12 weeks, but you could see progressive changes happening in both the gene expression level and the flow cytometry level. If we looked at, we were in this stage now, we're trying to identify targets. And so we had a genetic selection that looked for AML restricted gene analysis, differential expression in our CBF GLIS cord blood cells versus the control cells, genes or gene expressions where the protein is limited to the cell surface, and we had a target rating. Of this, we whittled it down to 6 different targets, which are listed here. FOLR1 is the one we chose to pursue. So FOLR1 stands for a folate receptor. There are several folate receptors, and there are several other groups that are working at this as being a targeted therapy. This here we're showing a flow cytometry tracing. The top row just divides this into the different populations, with the red representing the leukemic population. And you'll notice in each of these patient samples, they do express FOLR1. In the patient number 4, there was a lot of what was defined as normal blasts, which are the purple. And so the normal myeloid blasts did not express FOLR1, but FOLR1 was really limited to the malignant cells, which is depicted here. So FOLR1 expression is very specific for CBF GLIS AML, as it's not found in any of the other AMLs. And it's also not really noted in lymphocytes, monocytes, or myeloid cells. We then made a FOLR1 CAR T-cell, and these are the cell lines that were generated. WSU, AML, and this is the CG cord blood cells, had high levels of the fusion protein, where then we looked at Kasumi, which is a AML cell line that's not CBF GLIS derived, which did not express FOLR1, and these cells were transfected with a construct that had FOLR1. And you could see that when we added the CAR T cells to these cells, and here we're looking at specific cell lysis, we did see specific lysis using the CAR constructs in all the different cell lines that expressed FOLR1, but not in the Kasumi cells, and we did not see much lysis in the control unmodified T cells. These CAR T cells were then put into xenograft models using the same cell lines, and you could see here that this is, the cells were transfected with why am I blanking on it? The marker and monitored, and you could see that when we add the CAR T cells, you got rapid clearance of the malignant cells in the CBF GLIS cord blood cells, and the WSU AML cells, and in the Kasumi cells that express FOLR1. But the unmodified cells, the CAR T cells really had no effect. And so this resulted in a significant survival benefit in these cells. Sorry, this was luciferase was transfected into those. Then we used patient-derived xenografts that we could not add luciferase to, and we showed a significant survival benefit in these PDX, or patient-derived xenograft lines. While we were searching around, we noticed that there is a variety of antibody drug conjugates out targeting FOLR1. And so we reached out to a company that produces Stro-002, and we used their drug in these studies, and we showed a significant survival benefit on these cells using 2 different doses of Stro-002 in both the MV411 cells and CBF GLIS cord blood cells. So Sohail has started, he used to be head of the myeloid leukemia and COG, but a lot of people contact him for advice. And so he started using this FOLR1 as a compassionate use, Stro-002 on a compassionate use basis. It has not been, there's not a formal clinical trial yet, but he is showing significant efficacy where 40% of patients were able to get into MRD negative complete remission, and with another 53 getting into a partial remission, and it really had no side effects. So you could keep giving it to these patients even after a bone marrow transplant. In Sohail's words, he's never seen an effect like this. It's one of the greatest things he's seen, although I'm sure it's probably limited, as a lot of target therapies are. But the question is, can you get this as a bridge for transplant? We are now working on getting clinical trials for our FOLR1 CAR T-cells and setting up a clinical trial with Stro-002 targeting this form of aggressive AML. And FOLR1 is also expressed in ovarian cancer and osteosarcoma. So we've recently started an osteosarcoma model to look at. So in summary, CBF GLIS induced acute megakaryocytic leukemia. The endothelial co-culture system does provide a tractable model for long-term culture of these cells. It will allow us, if the fusion is not sufficient to produce the leukemia, we can then add other modifications to try to see what else is required. It mimics changes present in the clinical samples. I didn't show you that. And it facilitates drug and genetic studies, and it preserves self-replication in colony-forming assays. CBF GLIS acute megakaryocytic leukemia has these unique adhesion properties that may impact its resistance to therapy. And right now we're trying to treat our mice with plerixafor to see whether we can break up this interaction a little bit. When we looked at the gene expression pattern, there was an awful lot of adhesion-related proteins that are expressed in this model. FOLR1 does represent a very specific target for CBF GLIS acute megakaryocytic leukemia, and FOLR1 CAR Ts and Stro-002 are very effectively eradicates or comes close to, at least it improves the survival of the CBF GLIS acute megakaryocytic leukemias in xenograft models. So with this model system we have generated, there's a lot of potential for future studies. Sohail's much more interested in the therapeutic benefits. I'm much more interested in the leukemia genesis and what's really happening. I would like to define the molecular changes that promote transformation from the cord blood to the megakaryoblastic leukemia, investigate this cohesive nature, define and characterize the leukemia-initiating cells. We do have some flow cytometry studies that seem to indicate that there is a distinct population of leukemia-associating cells, but we have to go back and sort them and look for self-renewal properties. Studies on the cell of origin, whether it be fetal liver, cord blood, or adult hematopoietic stem cells. I want to expand the effort to target ERG or ERG-induced genes. There are some ERG inhibitors out there, and I did throw one onto cells, and they became polyploid. I don't know if that was sort of inducing a megakaryocytic differentiation, or there were reports stating that these ERG inhibitors, which are not that specific, were also inhibiting tubulin. And so maybe I just got a mitotic block. We want to model other pediatric AMLs with fusion proteins. And finally, we have clinical trials in the work with both FOLR1 ADCs and CAR T-cells. These studies represent a huge amount of time. It's been a long time since I presented here. Cyclin E studies were done in collaboration with Alex Manella in Jim Roberts and Bruce Klerman's lab. Sleeping Beauty studies were done in collaboration with Bridget Hughes in Bruce's lab. And the CBF GLIS studies were done in collaboration with Qui Li in Sohail Mashensky's lab, with a huge cast of people helping us. I tried to work by myself in my lab, and it gets very frustrating where you have one technician and you end up troubleshooting the whole time. So it was just great working with Sohail's group and really seeing how quick these projects could move. A lot of the flow cytometry for COG is still done at Hematologics, and they are a great group to collaborate with. And then I also want to thank the different pathologists at the Fred Hutch for discussions. This is the funding source. I was told to present this for evaluation, and my thank you slide, and I'll put that back up because I can never get that to shoot on my phone in time. If anyone has any questions, I'll be happy to address them.
Either any questions?
CBF GLIS because you saw an association with ERG and CBF GLIS?
I don't know that. In general, you think about the pediatric leukemias as not having many other mutations. And in the preliminary analysis, although I do want to go back to it, but in our sequencing of our transfected cells, we're not seeing other mutations that have developed. But yeah, I would think over growing cells in culture for 12 weeks, I would assume there's probably some other mutations that may have developed.
So Keith, I would ask, first of all, it's interesting about the whole thing with the folate receptor, because obviously folate is a very important nutritional component for, at least for red cells, and probably other bone marrow cells too. Is there any thought that you might be able to target some of these leukemic cells just on a nutritional basis?
So we've tried to treat them with methotrexate, and we've tried to grow the cells in folate deficient media. So far, we have not quite gotten that, but I mean, it's a very good idea. It's a great question, and we are thinking. There are lots of different folate receptors, and I think that these cells probably express some other folate receptor.
And then the other question I would have is, do you have any idea what it is that the endothelial cells are doing for these cells when you're growing them in culture?
I do not. Qui wanted to really get into that, and right at that point we were pushing pretty hard. So I know that Cyrus has indicated, he's done a genetic screen, and he indicated there was a variety of integrins that he thought that they were being secreted. And I'd like to sort of collaborate with him and figure out, is that what's happening here? Okay.
Well, thank you, Keith.
Thank you. Thank you for attending, and thank you out there in the Zoom world for attending. And I can always be reached for questions via email.